Welcome to the Deep Dive. Today, we're tackling something central to our practice, managing lower limb radicular pain, specifically looking beyond those standard epidural steroid injections.
Exactly. We all know they work, often quite well initially, but that long-term efficacy, well, it can be limited.
Right. It leaves us wanting more options, doesn't it?
It does, and that really highlights the need for, novel adjuvants, ways to make these injections work better for longer.
So that brings us to the core of today's deep dive. We're unpacking a recent randomized clinical trial.
That's right, a head-to-head comparison, essentially. It looked at adding either dexmedetomidine or magnesium sulfate to the standard dexamethasone injection for this kind of radicular pain.
And the key question they asked the mission for us today is really about the 6-month efficacy. Which one, if any, provides that sustained relief we're looking for?
Precisely. Let's get into it.
Okay, so the study design sounds solid. Prospective, randomized, double-blind. Tell us a bit about the patients they included. Who are they focusing on?
Certainly. They recruited 90 patients, all 25 or older, and crucially, these were folks with unilateral lower limb radiculopathy, specifically from a lumbar disc prolapse. And importantly, their pain had been refractory, meaning it hadn't responded well to conservative treatment for at least 3 months. So these are patients who really need something more effective.
Makes sense. Focusing on that tougher to treat group.
Yeah.
And how did they actually structure the interventions? You mentioned 3 groups.
Yeah, exactly. Everyone got a single transforaminal lumbar epidural injection, but the contents varied slightly.
Okay.
Group 1 was the control group. They received 4 milligram in dexamethasone, the standard steroid, plus 40 milligrams of 2% lidocaine for local anesthetic effect, and 1 LML of saline as a filler, sort of the baseline.
Got it. Standard procedure.
Then you had the magnesium group. They got the same dexamethasone and lidocaine, but instead of plain saline, they received 200 milligrams of magnesium sulfate mixed in.
Okay, 200 milligrams.
And the third group, the dexmedetomidine group, received 50 micrograms, sorry, that should be micrograms, not milligrams, 50 micrograms of dexmedetomidine, again with the dexamethasone and lidocaine, plus saline to make up the volume.
Right, 50 mics of dexmedetomidine.
Yeah.
So clear comparison set up. Now, what were they actually measuring to see which approach worked best? What were the key outcomes?
The main thing, the primary outcome, was pain intensity. They used the standard visual analog scale, the VAS, which you know well.
Yep, standard VS.
As secondary outcomes, they looked at functional disability using the Modified Oswestry Disability Index, or MODI, helps gauge how the pain impacts daily life.
Important context.
And they also tracked analgesic consumption, specifically how much ibuprofen patients were taking. Fewer painkillers needed usually means better pain control from the injection.
Makes sense. And how often do they check in on these outcomes?
Assessments were done pretty rigorously. At 1 week initially, then at 1 month, 3 months, and finally at the crucial 6-month mark post-procedure. Oh, and of course, they carefully documented any complications along the way. Safety first, always.
Absolutely. Okay, so this is where it gets really interesting. The results, particularly over that longer time frame, what did they actually find?
Well, initially, things looked good for both adjuvants. Compared to the control group, both the magnesium and the dexmedetomidine groups showed significant reductions in pain on the VAS scale, better function on the MODI, and less ibuprofen use.
Okay, so early benefits for both.
Yes, and these improvements generally held up for 3 months for both groups compared to control.
3 months. But the million-dollar question is the 6-month follow-up. What happened then?
Right, and that's where a clear difference emerged. At the 6-month mark, only the magnesium group continued to show statistically significant improvements across all measures, VAS pain scores, MODI function, and ibuprofen use when compared to both the control group and the dexmedetomidine group.
Wow, okay, so magnesium's effects lasted significantly longer.
That's what the data suggests. The benefits seen in the dexmedetomidine group, while initially promising, tended to wear off by 6 months. Their scores started to look more like the control group again.
So magnesium seems to offer that more sustained relief we're often searching for. What about safety? Any concerns raised with adding either magnesium or dexmedetomidine epidurally?
Thankfully, no. The study reported no serious procedure-related complications linked to either the dexmedetomidine or the magnesium sulfate. That reinforces their safety profile for this type of administration, which is obviously critical.
That's reassuring. So if we think about why magnesium might have this longer-lasting effect, any thoughts on the mechanism?
Well, that's where it connects to the known pharmacology. Magnesium is a non-competitive antagonist of NMDA receptors. These receptors play a key role in central sensitization and chronic pain states.
Right, the NMDA system.
Exactly. So, by modulating that system, magnesium might offer more prolonged antinociceptive, that's pain blocking, and potentially anti-inflammatory effects compared to dexmedetomidine, which works primarily through alpha-2 adrenergic receptors.
So a different, potentially more fundamental mechanism at play for the magnesium group, explaining that durability.
That's the likely explanation, yes. It suggests magnesium might be interrupting the pain cycle at a deeper level, leading to that sustained benefit seen out to 6 months.
Fascinating. So let's wrap this up. What's the big takeaway here for us, for clinicians dealing with this challenging patient population?
I think the bottom line from this particular study is pretty compelling. Adding 200 milligrams of magnesium sulfate to a standard transforaminal epidural steroid injection appears to significantly extend pain relief and functional improvement, potentially up to 6 months for patients with refractory lower limb radicular pain.
That 6-month data point is really key, isn't it? We all see patients who do well initially, but then the pain creeps back after a few months. This suggests magnesium could potentially bridge that gap for some.
It certainly could. It definitely offers a promising avenue, and, it leads to bigger questions for clinical practice.
Such as?
Well, considering these sustained benefits and the good safety profile shown here, how might epidural magnesium start to shift our strategies? Could it become a more standard part of our toolkit for these refractory cases?
That's the provocative thought, isn't it? Where does this fit in our algorithm? And it certainly points towards needing more research, maybe comparing different doses or looking at different patient subgroups.
Absolutely. It opens up interesting pathways, something for all of us, listening today, to consider in our own practice and maybe even in future research directions. How could this data influence your approach?